So, so, good morning, everybody. Today we will be learning a very important uh, problem which we face in day-to-day practice, particularly in the ICCUs and the critical care unit, that is the long QT. And these are the long QT patients which is missed and mismanaged. Later on, patient developing multiple episode of VT, VF needing defibrillation, and this type of condition still can be diagnosed properly and managed, and the morbidity mortality can be reduced, particularly in the ICU setting. So I will be walking through the what you call. So in the next 15 to 20 minutes we'll be discussing regarding uh, the approach to the long QT, particularly in the background, the patient is developing VT, VF, principle of management, how to manage it pharmacologically, what are the options, and one clinical vignette which will I will be presenting to make the concept clear, how to identify and how to treat the patient. So coming first, what exactly is long QT? What are the patients in which we are thinking that patient is having long QT? The first, we should know long QT is a condition in which the patient QTC is prolonged. And this QTC prolongation is a mark that the patient action potential has been prolonged. And the action potential prolongation is due to the repolarization reserve deficiency, which can be due to the uh, mm, which can be due to what you call channelopathies, or it can be due to the patient uh, drug related channel blockade. And these are the things which we have to know when we are dealing. So patient, every patient who we can say the normal patient, the repolarization has an inbuilt redundancy, means there is a reserve. Whatever the action potential is there, it is not going to prolong. Depolarization and repolarization, when we are adding, it is called the action potential. So whenever the depolarization is getting faster, the repolarization also happening faster. Whenever the repolarization is not happening faster, the action potential will get prolonged, and this situation will happen in the patient who are having the long QT. It may be due to the channelopathies, in which we call as a congenital long QT syndrome, or it may be due to the blockade of the particular channels due to drug and dyselectrolytemia, where correction of those things will correct the abnormality. So long QT patient is having the repolarization reserve deficiency, which can be due to the channelopathies or due to the drugs. And particular situation will trigger the activities. So we call as a EAD, early repolarization abnormality, because most of the abnormality is happening in the earlier part of the repolarization. So it is called EAD. So the channels which are responsible, like the potassium channel or the sodium channels, are responsible for uh, making this triggered activity. I will come into this one. The first and foremost question whenever we are dealing with the VT, which is happening, is whether it is related to the long QT or not. If long QT is there, the next question to be answered is whether it is acquired versus congenital. So it is important to know that there are some conditions in which the QT can be prolonged, and these are the reversible. And drugs and metabolic abnormality like hypokalemia, hypomagnesemia, hypocalcemia are the important and causes of long QT. And these conditions can be due to some secondary diseases. It may be due to diarrhea, it may be due to the diuretics. So those conditions will lead to hypokalemia. And if the patient is having repolarization reserve deficiency, they will start throwing the VT and VF episodes. We should note these are the secondary event, because there is some reversible cause, and these reversible cause is leading to the prolongation of QT. And these important QT prolongation happen due to the IKR channel blockade. So there are a lot of drugs which either it may be antiarrhythmic or non-antiarrhythmic drugs which will act on the IKR channel, means internal rectified current potassium channels, which are rapidly opening and closing. So rapid closing channels are the site of blockade which happen, and particularly this is one of the important cause of developing VTVF due to the torsade by the sotalol, or you can say the class 3 drugs. And reverse reach dependent means the persons when the heart rate is going low, these drugs will be more effective. And this thing happen more in the female. So if you are not having the reversible cause, then we have to give a thought about the congenital uh, QT prolongation, which is happening due to the gene mutation. Mostly the patients will be presenting under 20s, but yes, 40 to 50 age group presentation has been reported. Usually there may be a triggers, means the patient may be having a syncope or the seizure episodes while swimming, or due to the alarm bell, or due to the exercise or emotional stress. So baby who is playing all of a sudden at the peak of playing time, all of a sudden fell down and later on start throwing the seizure, always suspect that it may be a case of long QT syndrome. And syncom is the one of the commonest presentation of the long QT syndrome. Around 10 to 15% of patient, the sudden cardiac death is the presentation. So around 10 to 50% of patient who are coming for the sudden death in the family, they should be evaluated for the long QT syndrome. And whenever there is a syncope and seizure, because both are the channelopathies, one is for brain, another for the heart. If both are both the presentation is there, always and always think about the channelopathies as one of the etiology in the disease of disease, and long QT syndrome is one of the important. When a patient is having syncope or seizure, and on top the patient is having deafness, it may be a syndromic, and we call as a LGL syndrome, large and LGL syndrome, and or it may be a Romano word where the deafness may not be there. It may be associated with the scoliosis in the like Anderson syndrome, or it may be with the behavioral abnormality. So these syndromic type of presentation will be there, but we have to make sure the patient is not having any QTC prolonging drug, and it should not have any reversible cause like metabolic abnormality before landing up. And this is becoming more with a clinical scenario. If a patient is presenting with with a normal heart, and the patient is having under 20 presentation and swimming, means the triggers are there, we can suspect. But when the patient is having a different type of presentation, means there is a drug and metabolic abnormality, we have to correct and we have to check. But the final and foremost way to establish the diagnosis when we are in the doubt is the genetic studies, gene studies. So regarding the symptom, we should remember the three S presentation, means syncope, sudden death, and seizures. If these are happening in a family or it is happening in a particular patient, we should always suspect. And these syncope or seizure-like activity will be happening particularly in the particular circumstances. Usually in the long QT1, it will be happening the when the person when the baby is or the person is having swimming, emotional stress, or rugby playing. This typical presentation will be there while playing. All of a sudden, he become faint and later on start throwing the scissors. So this type of thing are usually under 15 males. In the female who are in the postpartum period, or the babies who throw scissors or syncope due to the auditory stimuli like a doorbell or the alarm clock, those type of patient is having long QT2. And in the long QT3, where the patient is having agonal breathing pattern and sudden death, usually in the sleep hours, these are common in the long QT3. And long QT1, 2, and 3 comprise around 90% of the long QT syndrome. So whenever a particular circumstances has been found in the family of the sudden cardiac, if it is sleep, it is this, the long QT3 should be suspected. And if it is during the exercise or during swimming, the long QT1 has to be seen. So these are called the phenotypic presentation of the long QT syndrome. But the establishment of these diagnosis requires not only clinical but the genetical studies also. ECG is very important, and when we have to see the ECG, it should be the all the previous ECG we have to go through. Like when we are appearing in the examination, we have to see the previous questions. Same thing is applicable when we are dealing with the channelopathies. We should not be complacent with one ECG and seeing there is no long QT or that the QTC is normal. So we have to see all the available previous ECG, including the halters. And if we are suspecting the patient is having long QT, it may be possible that some of the QTC may be prolonging, some of the patient may be throwing the long short cycle, and patient may be having the VPC initiating the short run of VT. So this type of episodes has to be suspected, and I am repeating, all ECGs, previous ECGs of the patient should be looked for the long QT and channelopathy like Brugada as well as this. So channelopathies, the ECGs will not be fixed, and repolarization activity will be available in not all the ECG, and repolarization abnormality will be visible in some of the some of the ECG, and that should be looked for the T wave morphology and how QTC is prolonging. In some patients, when we are not able to make the conclusion, we want to challenge the patient's QTC, and by doing the treadmill test, which is one of the tests which is usually interventional cardiology is used for seeing the whether the patient is having ischemia due to the significant block. But as electrophysiology, we also do the TMT, and here the TMT provide the repolarization reserve of the patient. The persons who are having the QTC prolonging at the recovery time, 4 minutes later, is taken that the patient is having repolarization reserve deficiency. It may be due to the uh, gene abnormalities, and it has been way to establish it is when it is happening, if it is happening at the peak, or it is happening 4 minutes later, or if it is not happening or it is shortening. This may differentiate which type of long QT is there. So phenotypically differentiating the type of long QT can be done by the treadmill test. There is a SWOT scoring system which is based on some of the findings like the how much QTC is prolonging, 4 minute QTC recovery time, what is more than 400 meters, torset has been noticed or not, T wave alternate is there, notch T wave there in the lead 3 or not, and the low resting heart rate. These are the some criteria which is being applicable, and the patient is having syncope or congenital deafness, that going to add on. And this scoring, if you do more than 3.5 seconds, it is taken as one of the criteria for diagnosing the long QT syndrome. 90% of long QT syndrome is due to the long QT 1, 2, and 3. And as we know, it is due to the channelopathies of potassium and sodium. But up to 50% of patient, whenever we are doing the long QT evaluation in the ECG, it may be concealed or it may not, it may be having a borderline. And these type of patients, where we have to do some provocative test and to unmask the long QT. In this, the epinephrine test, the Mayo protocol, we give the epinephrine at 0.5 milligram for 0.5 microgram per kg as a bolus, and then continuous 0.1 microgram per minute. What is happening with the QTC over the time will diagnose. If the QTC is prolonging at the steady state more than 35, it is a long QT1. If it is not, then we have to see at the peak what is happening. If it is increasing more than 80 millisecond, yes, it is a long QT, and if it is not, then it is a control or long QT3. So epinephrine provocative test is one of the way to establish the diagnosis. So steady state is reached by 3 to 5 minutes and peak is 1 to 2 minutes. In patient who is having a long QT or suspected to be having a long QT, a QTC of more than 480 millisecond at 4 minutes of the recovery is taken as 100% specific for the long QT. So whenever you are suspecting you are not able to do the provocative test, doing a treadmill test is a best way to establish the diagnosis. Not only that, we are having one drug by the name maxillotin, which is available, and this drug, when we are giving to the patient, we can differentiate the phenotype also, long QT1, 2, and 3. In long QT1 and 2, it reduces the QTC interval, but it is not that much, between 40 to 45. But in the long QT3, where the QTC is there, the QTC shortening is more than 150 millisecond. So it establishes one of the phenotype like a long QT3, the QTC is shortening, markedly shortening, and at the same time, it gave the prognosis also. If the QTC is prolonging, then we can think that mexiletine is one of the drug that can be added, particularly in those patients who can't afford and in which we can't implant the AICD due to some reasons. So what are the treatment of long QT? So remember the three Ds, that is a drug, device, and denervation. So drug, propranolol, Inderal, what we can say 2 to 3 milligram per kg per day. This is important because a 30-year-old, 30 kg boy, we have to give at least 60 milligram, and usually underdosing is one of the reason of under treatment of the long QT. If the patient is intolerant to the propranolol due to the asthma, or the patient is having a low heart rate, then the Mexohar, or you can say Mexiletine, is the other drug, and it is usually given in 4 to 8 milligram per kg in three divided doses. So these two drugs are the important sheet anchor treatment. Never rely on the metoprolol, because metoprolol is a selective. Even the bisoprolol is also selective, and we are having a limited data regarding the use of these drugs in the long QT. Most of the studies of the long QT has been done by with a nadolol, which is a non-selective beta blocker, and followed by propranolol. So always and always choose propranolol wherever possible, and particularly in our country, propranolol is one of the best drug, cheaper and available at every nook and corner, by name Inderal or Ciplar. We can try it and give appropriate dose 2 to 3 milligram per kg in divided dose. If it is a long acting, you can give once or twice. That's enough. But if the patient is not a candidate of this one, or is not tolerating, or is still throwing the VT and VF episodes, then AICD is AICD is a device we will say automatic implantable cardiac defibrillator. And these are the patients in which implanting the AICT will be preventing the sudden cardiac arrest, or salvaging the patient from the cardiac arrest due to the long QT. So this therapy is an important part, that is called the second D, that is called the device therapy. And some patients who are not doing very good on the beta blocker, or they are not intolerant to beta higher doses, the denervation, because sympathectomy can be one of the treatment, and it should be done in wherever possible, where beta blocker is not well tolerated, or even after beta blocker the patient. So denervation is important therapy. So three Ds, remember: drug, device, and denervation. Now coming to the management point of view, and here whenever we are establishing a diagnosis of long QT, and we have to first pinpoint whether the patient, we have to check the checklist the patient's medication, particularly if the patient is in the ICCU or he's on the multiple medication. The offending drug which is leading to long QT should be removed from the list, particularly if it is not required. And in those, most of the time we are having alternatives which can be given, in which doesn't increase the QTC, or which having a minimal effect on the QTC. So those drugs we have to make choices wherever possible, and particularly in the antibiotic, the patient is having illness in which we are giving the drug. Second important thing that we have to do in all the long QT patients when they are presenting the VT, we have to correct the potassium in the acute setting, and it should be kept between 4.5 to 5 milliequivalent per liter by whatever way, IV route or the oral route, and IV route will be the very fast way to correct it. Third and most important, where it is undertreated, that is a IV magnesium. Usually people, doctors give 1 or 2 grams and then say they become complacent. But I want to highlight that magnesium is one of the important membrane stabilizing medication. You can go up to 12 milligram, 12 grams. 12 gram means you can start at 500 milligram per hour for next 24 hours by the infusion pump, provided the patient renal function is good. In this situation, certainly you are going to salvage the patient from the VTVF episodes and the long QT induced torsades. And wherever, when the patient is having on and off VT ongoing even after giving these drugs, if you are at the place where you are not having putting a temporary pacemaker, you are having the choice to put isoprene in. So either put an infusion of isoprene, or if the patient is if you are at a place where the TPI can be done, temporary pacemaker, you can put a TPI and the things will be done. It stabilizes the QRS interval, or you can say the ventricular depolarization, and SLS, what is called short sequence, which is important cause for the VTVF, can be taken care. So principle of management, So long QT, wherever is there, drug and denervation is the first, and where the patient is not tolerating or the patient is developing bradycardia and patient is young, the pacemaker is one of the therapy. The single chamber pacemaker can be implanted. If the patient is having anytime cardiac arrest, then AICD is a treatment with beta blocker and maxillotin. And usually this is indicated in any long QT if the patient has having one cardiac arrest, and particularly in the type 3, it is one of the important treatment or what one of the reliable treatment for the preventing the sudden cardiac death. Now coming to drug choices, so beta blocker is preferred for the long QT1, long QT2 and 3. It is not that much effective. The effectivity reduce as we go from the long QT1 to long QT3. It is less, at least no more effective in the long QT3, but long QT1 it is very reliable and effective treatment for the long QT congenital long QT1 syndrome. Nadolol is the drug which is mostly studied, and propranolol is the most available and most effective beta blocker in the long QT syndrome. So long QT, whenever suspecting, don't start with metoprolol, go for the propranolol. And in the Western world, it was the nadolol on which all the studies has been established regarding the safety and effectivity of beta blocker in the long QT. Where the patient is not tolerating propranolol or the patient is developing bradycardia, there the role of the maxillotin, which shortens the QT effect, shortens QT interval, and sometimes it is diagnostic also. So long QT wherever is there, or long QT3 is there, or patient is not tolerating the beta blocker, it is preferred to put the patient on the maxillotin. Long QT2 patients, long QT2 syndrome, the whenever you are giving long QT2 patient, it shorten the QTC interval. So QTC shortening is happening in the long QT patients with maxillotin. So with maxillotin before and after, you can see 80 millisecond there is a QTC shortening. So this is one of the drug which shorten the QTC in the long QT syndrome patient. Rest of the patient, it has got neutral effect. Long QT3 syndrome patient, maxillotin is one of the way to establish also whether the patient is been having a reliable effect with the maxillotin or not. So if you are giving maxillotin 6 milligram per kg per day, and after 3 hours of giving maxillotin, the QTC is falling below 500, we can still bank on, or we can vouch that maxillotin can be a drug which can be given in the long QT, provided the patient is not having cardiac arrest. Cardiac arrest, whenever it is happening, we have to go by the AICD implantation. So it not only establishes, but it is therapeutic also. Now coming to the one of the case presented almost 5 years back to me, the patient is having 45-year-old female having giddiness and syncope, fever and cough was treated outside, and she was being treated with some medication. Later on, she was having VT episode for which she has been loaded with amidron, and after that amidron, the patient was having 25 DC shock and referred to us for the AICD implantation. So this is a very common scenario which we deal in our practice, because the patient has been referred to the center that probably your VT is not going to resolve and you have to undergo the device implantation, we call as AICD. So let us make some conceptual point clear at this point, that whenever the patient is having ongoing VT episode and patient is having more VT episode, means you have already given DC shock, we have not to implant AICD. It is a contraindication. So in this situation, we have to find the reason. And in this patient, if you can see, the important thing that is very important to, I want to highlight, this is called long, short, short, long, short sequence. Means there is a short interval after the sinus and there is a VPCA scan. Then the long pause has happened due to the compensatory pause, and then again a short sequence and the VT has started. This is SLS sequence, and this type of sequence will be the driver of the VT. So wherever it is happening, we have to break this SLS sequence by first stop the amidron, which is driving it. Second, give the magnesium. You can go up to 12 milligrams, 12 grams of the over the infusion. Correct the hypokalemia from 4 to 4.5. And in this situation, since we want that the SLS sequence should not happen, we have to put the patient in the overdrive pacing. So whenever we are pacing this, these intervals will be having a uniform and the chances of developing the VT will be less. So in this, we have done all the four things, and later on the patients recovered from no episode. Potassium was corrected, magnesium was given for 2 days, hypokalemia was also corrected urgently, and third day the patient overdrive pacing was stopped and she was taken off. Her baseline QTC was bit higher, it was around 490, but after 2 weeks the QTC has been normalized and it looked like to be drug-induced long QT syndrome. But she is a female. We have not done the genetic study, but yes, genetical insight will certainly give whether it is a drug-induced or it is a congenital, very borderline or concealed long QT syndrome. But the therapy will be there that we have not to give amidron. At this point, it is very important that we should understand the long in any patient. Most of the time, when the rhythm problem is happening, this event, long treatment leading to VT, we have to correct it. And usually, the long QT syndromes are associated with this thing. But sometimes, without this, also means maybe non-pause dependent or the T wave alternate can also throw the VT. So, whenever is happening, it is a mark that the patient is having repolarization reserve deficiency, and in those situations, long QTC prolonging drug has to be avoided, and the circumstances or a trigger has to be avoided. Since in the last case, we have seen that amidron is one of the drug which has been very reliable for treating all sort of SVT, VT, atrial fibrillation with fast ventricular rate. But as we know that, as we have been taught in the medical science or in the pharmacology, we should know the contraindication before the indications. And we should know where not to give amidron. So amidron should not be given in the long QT or any suspected case or long QT or torsade ongoing. So here, if you are giving, you are in this, you have to face the music. The person will be having more episode of VT, which will be uncontrolled by the amidron. So amidron is not going to prevent or it is not going to treat, it is going to prolong the QTC and further torsades will be happening and the patient will be throwing VT and VF, which was happening in that case. And second, the patient if is having wide QRS tachycardia and the baseline is showing delta wave, in that type, wherever there is a irregular, either it is a torsade, torsade or it may be irregular wide tachycardia due to the WPW syndrome. Both the situation we have not to give amidron. So amidron is contraindicated in torsades, and second, wide QRS tachycardia with baseline is showing delta wave means there is a component of WPW syndrome. So in this situation, never ever give amidron. Better to be safe, give shock, and wherever like in torsade, we have to correct the electrolyte or the drug leading to the torsades, not the amidron to be provoke the further torsades. Wherever the long QT syndrome, the first treatment is cardiac arrest on the high risk. It is AICD and left-sided sympathetic denervation can be done. If the patient is aborted with cardiac arrest, certainly the one of the drug ICD beta blocker and mexiletine with left-sided sympathectomy should be done. But patient who is presenting with syncope on the beta blocker, then left-sided sympathectomy and re-evaluate if it is less than 500, no ICD. If it is more than 500, mexiletine, and we should consider AICD. If the patient is having any syncope, even on sympathectomy with and without mexiletine, or any cardiac arrest has happened, then AICD is the first treatment. So cardiac arrest, AICD. If it is not a cardiac arrest, it is a syncope, then certainly we can go for the sympathectomy with beta blocker. And if beta blocker is not responding and not tolerable, then again mexiletine with AICD is the treatment. So take home message for this presentation that wherever you are facing a long QT or the VT ongoing, first and foremost, check the QTC. If it is prolonged and QTC has not to be seen the baseline in the ongoing VT. We have to see what was the baseline before the patient started throwing the VT. And if it is prolonged, look for the drug. If the patient is on multiple drugs, check the electrolytes. And if they are deranged, correct it. If after the correction the things has settled down, it may be a case of acquired, and that this type of drug has to be avoided, and the electrolytemia should be treated aggressively, because some of the patient may be having a latent long QT syndrome, and these drugs or dyslipidemia are driver or trigger for those events. If it is not, like the patient who are young, who are not having any reversible causes, look for the long QT 1, 2, 3. ECG will be having marker, history, pedigree, exercise history, and genetical testing will provide the insight. SWOT scoring will certainly establish, and wherever the things are still in the border zone, genetical testing should be done. TMT is a very commonly available test. Do the TMT and 4-minute QTC prolongation. If it is more than 480 milliseconds, it can also provide the insight that we are dealing with a long QTC in the baby. The risk stratification, if the patient has any time having a QTC more than 500 and cardiogenic syncope has happened or cardiac arrest happened, these are the patient where the drug has to be avoided, which prolong the QTC. We have to give the safe and the exercises which increases the QTC, or the exercises we have to prevent. Beta blocker, maxillary is the choice, and anytime if the patient is having cardiac arrest, then we have to put the patient on the AICD with left sympathectomy. Age, sex, and genotype will certainly provide some insight when we are in the borderline zone where we are not able to make that conclusion, and where the pedigree is favoring a very aggressive, or we can disfavor type of genotype. So in those situations, we have to put the patient on the AICD. Thank you so much for for your patient hearing. You can drop your questions in the comment box. Wherever possible, I will try to answer. Thank you so much for your patient hearing. See you next time with some important clinical cases related to arrhythmia. Till then, bye bye. Thank you.